problem we face because it has an identity crisis. Unfortunately, identifying GERD is not so easy, and I'm sure you all have your fair share of patients coming to you with a mumbo-jumbo of mixed up symptoms. That's because many other conditions mimics GERD. Peptic ulcer disease or gastritis being the most common. Then we have angina, the patient will complain to you with recurring chest pain or even heartburn, and they may sound just like GERD. Then we have the most life-threatening condition that actually mimics GERD, which is the heart attack, or even the most devastating diagnosis that you could give your patient, which is the esophageal cancer, and they do present with GERD-like symptom as well. And finally, the uncommon conditions such as achalasia cardia, and they too present with GERD-like symptoms. And finally, I'm sure most of you will concur, patients with anxiety or psychiatric problem, they are the most difficult to treat, most difficult to manage, and they present with symptoms mimicking GERD as well. There are 5 types of refluxates that can backflow into the esophagus. Most of us are familiar with acid refluxes, but air, fluid, solid, as well as bile can reflux into the esophagus. And these non-acid refluxes also contribute much to the GERD problem. All right. Now, this is the list of pathophysiology for gastroesophageal reflux disease, and as you can see, they are multifactorial, and this is also the reason why PPI alone does not relieve GERD. While the other in the list can be managed on patient's part, I would like to draw your attention to 3 highlighted lines, because it is these 3 mechanisms that, for the lack of better word, a more advanced or a more specific targeted treatment is needed, which we will speak on further. Mainly, the structural and physiological anti-reflux mechanism of the gastroesophageal junction, the lower esophageal sphincter relaxation, as well as the esophageal clearance mechanism, which is the target of our treatment. What are the symptoms of GERD? There are 4 typically symptoms occurs for GERD after meal. And as we have mentioned, your patient with GERD will complain of multiple symptoms. But if you listen carefully enough, you will find them to fall into at least one of these 4 categories. And from here, a GERD score can be formulated by performing a GERD-Q questionnaires. A score of 3 to 7 will mean the likelihood of GERD is about 50%, while a score of more than 8 means the likelihood of a clinical diagnosis of GERD is 80%. However, you will find that a large group of patients will complain of coughing, and these lead to bad breath and sore throat. The coughing usually starts early in the morning. A patient will tell you that they will cough until they are awake from sleep. They will tell you that they have lots of phlegm. And there are another group of patients where they complain of coughing, particularly at night when they are lying down. And and as we have mentioned, this coughing and phlegm leads to bad breath and sore throat in the morning. Therefore, you won't be surprised to find some of these patients actually consult ENT and your dental colleague before coming to you. Now, what are the causes of GERD? These are the 4 most common causes of GERD. Hiatal hernia being one of them. So what is hiatal hernia? if you can appreciate the picture on the right, you will find that in the normal patient, the esophageal sphincter and the diaphragm situated in the same level. But when the hiatal hernia occurs, the esophageal sphincter migrates above the diaphragm into the thorax. Therefore, the proximal stomach actually herniates through the hiatal into the thorax, therefore producing hiatal hernia. And when the esophageal sphincter is no more the same level as the diaphragm, the lower esophageal sphincter mechanism and its protective mechanism will fail, and the content from the stomach will backflow into the esophagus. The second cause of GERD would be esophageal dysmotility, and this is one of the hardest or the most difficult to be diagnosed. It is a functional problem, and in this picture in this X-ray on the right, you will see that the esophagus exhibits tertiary peristalsis, where jerky, short, spastic peristalsis of the esophagus is being demonstrated with this contrast. It is very difficult to be diagnosed via a radiological method. It is mostly diagnosed with high resolution manometry, and it is easier to be diagnosed by that. And then the most common causes would be the dietary habit of patient. Oily food, the amount of intake that the patient takes, the type of food that the patient takes. All these it could be irritant, and they could slow down the gastric emptying, could slow down the digestion, thereby causing gastroesophageal reflux. And it becomes a problem when it becomes a disease when the reflux causes changes or irritation to the esophagus. Body habitus such as congenital abnormality, as you can see in this patient with severe scoliosis, the angle of his and the stomach position is actually abnormal, thereby making the protective mechanism of the lower esophageal sphincter to fail and causing reflux. And of course, finally, patients that are obese, patients with high visceral fat will have increased intra-abdominal pressure. And as you can see in this picture, patients with lots of visceral fat will of course will have gastroesophageal reflux, as the increase in intra-abdominal pressure alone may cause the stomach to herniate into the thorax. So how do we investigate for gastroesophageal reflux disease? One of the easiest and the commonest and easily accessible method would be the OGDS, or esophageal gastroduodenoscopy. What we will find would be one of the four causes above that we have mentioned. This is a picture of hiatal hernia. As laid out from left to right in the screen, you can see that grade 1 is the is the mildest of them all, with grade 4, where you can appreciate the stomach folds, this rugae of the stomach herniating into the hernia, and you can see a large defect where our endoscope comes through, and this is a grade 4 hiatal hernia. In grade 3 and grade 2, the stomach folds is still within the stomach. It has not herniated into the hiatus, and that differentiates a grade 4 from grade 2 and grade 3. And if you see this 6th picture on the right, this is a hard sign of reflux, because this is sign of esophagitis. Esophagitis means the inflammation of your lower esophagus, so it is caused by refluxates injuring the mucosa of your esophagus, and this is a hard sign, and this is a hard evidence that the content of the stomach is refluxing into the esophagus, and it is causing a problem to your patient. Now, more importantly, from esophagitis, even if the patient do heal, 1 or 2% of the population will develop Barrett's esophagus, and over time, this Barrett's esophagus will progress to low-grade dysplasia, and if it's not followed up or treated properly, they become high-grade dysplasia, and finally they progress to esophageal cancer, which is the most devastating diagnosis that you can give your patient. So when is it timely to refer for endoscopy? It is indicated if there's a change in the management on the basis of endoscopy, when there's unsuccessful empirical treatment, or when there's initial evaluation apart from radiological method, or when a therapeutic procedure is required. But most importantly, when the problem is recurrent, it is protracted, please do refer your patients for endoscopy, even if it is just for screening. Now, there are other investigations that you could do as well, such as the radiological CT scan. An example here, you could see from the CT scan clearly that the hiatal hernia in the chest. You can differentiate this from the CT scan on the right, where esophageal diverticulum, which is not part of the hiatal hernia. So the CT scan helps you to exclude other diagnoses as well as extra anatomical diagnosis. Now, the most important for me to diagnose gastroesophageal reflux disease and to rule out other disease as well, I think would be high resolution impedance manometry and the 24-hour impedance pH study. I think these two adjunct investigation greatly help us upper GI surgeon to diagnose GERD. So how is the high resolution impedance manometry performed? As you can see on the picture on the right, it is performed with a probe through the nose, and it will generate picture like this. If you can appreciate on the normal picture here, the lower esophageal sphincter and the diaphragm in the same level, and this red bar is the upper esophageal sphincter. As the liquid bolus moves from the top of the esophagus into the stomach, you can see the peristalsis being shown in this impedance resolution manometry. However, in hiatus hernia, you will see that there is the separation between the lower esophageal sphincter and the diaphragm. How do we know that this is the diaphragm? You can see that there is interval in the pressure indicating respiration, because the diaphragm is involved in your breathing. So the lower esophageal sphincter and the diaphragm is separated, and this length actually constitute the length of your hiatal hernia. Then we have the 24-hour pH monitoring. With the advance of impedance in the pH study, now we can even diagnose acid reflux versus non-acid reflux. A little bit more on the manometry. So this is how the manometry probe is inserted into the patient. It is just like a nasogastric tube insertion. Patient is needs to be awake. We will insert the probe via the nostril into the esophagus, about 5 cm above the lower esophageal sphincter, and then patient will perform liquid swallow. Usually we take an average of 10 liquid swallows, and the computer will generate this color imaging, impedance imaging, and we will interpret the result from there. This procedure usually takes about 20 to 30 minutes. Patient usually does not complain of much pain, and it can be done as a daycare or outpatient procedure. The 24-hour impedance pH study, however, it's done over the course of one day. We have the wired impedance or the wired pH machine. Likewise, a tiny probe is placed into the nostril and then being connected via this tube into the monitor or the recorder. Patient can go about their daily activity just like this man here, and the probe and the recorder will record the pH and the reflux in the esophagus as well as the stomach, and it also records the symptom that the patient which the patient can press a button to record it so that it coincides with our pH and the reflux incidence. Now, how do we treat GERD? There's no running away from giving this advice. I'm sure most of us have given this advice, and I think patients are also quite familiar with this, but unfortunately there is nothing to replace lifestyle and dietary modification. We have to reduce oily food, we have to reduce gaseous drinks, because these food reduces or slows down the gastric emptying, therefore actually can induce reflux into the esophagus. Gaseous food, gaseous drinks, they produce gas, and therefore the air can reflux into the esophagus. So there is no medication which can replace lifestyle or dietary modification. We have to reduce the intake at one go. So patients who have habits of eating a lot of food at one sitting, as you can see from this x-ray, the entire stomach is filled up. Of course, there is a higher chance for this patient to have reflux. So therefore, patients have to consciously reduce the intake per sitting. They should have smaller meals, more frequent meals, as well as timing. They should take timely, they should be taking food in a timely manner. Exercise and weight reduction will help to reduce reflux, as you can see in this obese man, where there is such thick subcutaneous tissue and even increase in visceral fat, and you can see the stomach is being compressed in this CT scan. Of course, this patient will have reflux. Exercise, weight reduction will help to increase the efficiency of your the efficacy of your muscles, and therefore digestion, as well as increase your gastric emptying time, so therefore reduces the reflux. So in a simplified manner, we could classify patients into heartburn, regurgitation, or group them into dyspepsia symptoms. From here, the alarming signs, if they should have alarming signs such as GI bleeding, or the problem has been protracted for more than 1 year, or there are significant weight loss, dysphagia, anemia, elderly, or if there is a mass that you felt, then a timely referral to upper GI center is recommended. However, if none of those alarming signs are present, diet modification, lifestyle changes, and losing weight would be recommended to the patient. They can try proton pump inhibitor for 8 weeks. If this works, PPI should be tapered and stopped. If the patient having dyspepsia symptoms instead, they should review, stop, and optimize any existing medication, test and treat for H. pylori. Then again, diet modification, lifestyle changes, and losing weight must be advised to the patient. Proton pump inhibitor can be tried for 8 weeks before tapering and stop. However, if this fails, a trial of domperidone can be given to patient, and if refractory symptoms persist, you could refer them to an upper GI center. So what do we do when patient comes to us? We put them through endoscopy. From endoscopy, usually we look at whether they have any atypical symptoms. We score them. Patient with a pH study of more than 4% of the time will be diagnosed as a NERD, while patient which has acid exposure time of less than 4% with symptom association positive, they are probably diagnosed with hypersensitive esophagus, and those that are negative, they have functional heartburn. Atypical symptoms warrants extra investigation such as manometry or CT scan, because we would like to rule out achalasia claudia, external compression, or even primary esophageal dysmotility. Now, the interesting part would be when we find something abnormal, when there's GERD or when there's tumor or malignancy. If there's GERD, anti-reflux procedure would be offered. With the advancement in our technology now, endoscopic anti-reflux technology such as transaral incisionless fundoplication using Endofix device can be used to treat GERD as well. It is found that this device can improve symptoms in patient even without hiatus hernia. However, they are inferior to Nissen fundoplication in restoring anti-reflux physiology. This is a relatively new technology. We do not have much literature or even long-term result on this. Therefore, it is yet to be seen how good it is. The strata procedure, this is how the transoral incisionless fundoplication is being done, where a device is being inserted into the stomach, and to recreate the angle of His. It does not provide any other anti-reflux mechanism. Therefore, it is understandable that in restoring anti-reflux physiology, it is less effective compared to a fundoplication. On the other hand, the strata procedure is where radiofrequency energy is being delivered to the lower esophageal sphincter. The hypothesis is that with this radiofrequency energy, it actually tightens the muscle by increasing scarring. There is no, as we speak, there are no hard evidence to show that the muscle actually do tighten up and preventing reflux. Meta-analysis of RCT did not show any increase in lower esophageal sphincter pressure or reduced exposure in acid refluxes. However, the patients do states that there is reduced symptoms, and we think that the symptoms reduction is probably due to the denervation of the lower esophageal sphincter mucosa. Therefore, the sensory mechanism of the patient are being reduced by this radio frequency. Therefore, patient tells you that they have less symptom. By and large, we do find that the patient that has performed strata procedure do recur. Now, the time tested and the most effective procedure till date would still be the anti-reflux surgery. The aim of an anti-reflux surgery is to achieve remission of symptoms and to reduce the acid exposure time of the esophagus. Thereby, we hope that with this, it prevents the symptoms from occurring, as well as preventing esophagitis and subsequent development of cancer. We aim to restore the physiology of the anatomical anti-reflux mechanism, and the procedure that is most commonly performed would be a laparoscopic fundoplication and cruroplasty. So this is a picture of the diaphragm view from below. As you can see, the one in the center is the esophagus. These fibers on the left are the right crust, and the fiber on the right is the left fiber of the right crust. And in this laparoscopic view, you can appreciate that this is the right crust, and this is the left fiber of the right crust. This is the esophagus being pulled by the tape, exposing a huge defect over here. So as you can see, with this large defect, the stomach could easily herniate into the hiatus, through the hiatus into the thorax. So what we do with cruroplasty would be we approximate these two fibers together using sutures, leaving about a 1 cm gap for the esophagus, so that to prevent dysphagia. And in the pictograph, this is what is achieved, where the hole is being repaired with sutures, and the length of the transabdominal esophagus is being restored in order to restore the angle of His. Apart from cruroplasty, fundoplication is also part of anti-reflux surgery. This is the normal stomach. There's 3 different types of fundoplication. The Nissen fundoplication, which is the 180 degree wrap, the toupee, which is the 270 degree wrap, and door, which is the 90 degree wrap or the anterior wrap. Most of us in Malaysia performs the Watson fundoplication, which is the door, which is similar to the door fundoplication. So it involves closure of the crura, and we reconstruct the angle of His by reducing the abdominal esophagus. Finally, the gastropexy is done to prevent the stomach from moving into the hiatus, and completion of the anterior wrap by suturing the fundus to the right crura as well as the esophagus. And this constitutes the full anti-reflux surgery. So this is the last slide. Successful treatment of GERD needs the correct diagnosis of GERD. GERD is a spectrum of disease caused by both acids and non-acid refluxes. Therefore, PPI alone does not treat GERD. Clinical diagnosis alone has a low specificity and have overlapping symptoms with NERD and functional heartburn. Therefore, adjunct investigations such as an OGDS, Manometry, or pH study would be very helpful to diagnose GERD. Because all being said, surgery alone or medication treatment alone is not the magic bullet. For successful treatment of GERD, we need the right patient, we need right diagnosis, and therefore we can deliver the right treatment. And with that, I thank you for your attention. These are my reference. Thank you.
Okay. Oh.
Yeah. Back.
Apologies to our audiences for the technical problems at the initial part of the talk. And thank you very much once again to Dr. Ooi Wei, our consultant upper GI surgeon, for a very insightful talk on this very common problem called gastroesophageal reflux disease. Okay, we'll take a 1 minute break. Please don't forget to give your comments or questions in the comment section. We'll come back to you soon. Welcome back once again to our live talk sessions. We have a few questions. Let's start with the first one. Thank you for the insightful talks regarding GERD, Mr. Ooi. However, I have a question as a GP. If a patient comes to me with GERD symptoms, should I prescribe patient with PPI immediately or refer for an OGDS?
Thank you for your question. Well, although GERD is common, but the gastritis gastritis or other stomach dyspeptic problem are even more common. Unless you are very sure that this is GERD, I think treatment with PPI, trial of PPI is very reasonable. The patients do not need to be immediately being referred for endoscopy. A trial of PPI, advice for lifestyle modification, dietary advice can be dispensed to patient, and you can follow up your patient unless this fails, or if there's any alarming symptoms, then maybe the patient warrants an endoscopy, and then that would be the time you could get a referral to an upper GI center. Otherwise, I think it is very reasonable for you to trial your patient, to put your patient on trial of PPI. Yeah, that is very reasonable and fair.
Okay. We have another question. How much weight does an obese patient with hiatus hernia need to lose before considering surgery? Is there a specific aim, like percentage of original body weight?
Yeah. Usually, we do not know. In truth, we do not know how much weight that the patient would need to lose. Before the symptoms improve. But by and large, we do see patients that having lost about 8 to 10% of their excess body fat do have better control of their symptoms. They feel the symptoms will reduce, they feel better about themselves. But yeah, truth be told, we do not have an exact number where how much weight or how much percentage of the excess weight should be lost before the symptom relief. By and large, this is also because there is, we have mentioned just now, GERD is the causes for GERD, the pathophysiology for GERD is multifactorial. There is not one single factor that produces GERD. Rather, it's a collection of few protective failure in the protective mechanism that produces GERD. But by and large, any weight reduction would actually, we have seen that patient actually tells us that they actually have better control in their symptoms. Yeah.
The next question comes from our in-house doctor. Any role of sodium alginate and baclofen in the management of GERD?
To be honest, I have no experience in using sodium alginate as well as baclofen for GERD treatment, but I would like to share that I do use sucralfate, which is a bismuth, for treatment for esophagitis, which is a complication of GERD. This sucralfate what it does is that it coats the mucosa of the esophagus as well as the stomach, giving it a protective barrier, allowing the mucosa to heal. And these patients tend to they tend to get better with this. But however, if they ease esophagitis, means the reflux is quite severe. So treating with sucralfate or PPI alone will most likely be temporary. These patients usually warrants fundoplication or anti-reflux procedure. Yeah.
I don't see any more questions. Is there any last question from the audience? Well, if not, we'll call it a wrap.
Yeah.
And Dr. Ooi, do you have any last remarks for our viewers today?
Yep. Do join us for the future search talk. I think the next one will be in
Somewhere in March, we'll announce the date.
Yeah, we will announce the date later. Yeah. Yeah. With that, I thank you for your for joining us today. And I thank Mr. Chong and as well as Sabah Surgical Society for inviting me for this talk. Yeah.
Okay, thank you. Once again, just a reminder, the Search Talk series are regular talk series on surgical topics, brought to you jointly by Sabah Surgical Society and Gleneagle Hospital. And to all doctors, please don't forget to scan your QR code at the end of these live sessions. Yeah, that's all. We'll see you again.
Thank you.
Thank you.